Hi there, everyone. Welcome to this presentation on the American Society of Addiction Medicine, or ASAM, patient placement criteria as it relates to both assessment and placement into treatment. This is the fourth edition guidelines. So for some people that may be new, these guidelines came out in 2023, 2024. They're still being established many places, but it is good to be familiar with some of the new language and terminology, as well as new placement dimensions that we have. So starting out on this slide, and I've already broken all my rules as far as not making a slide look too busy. There's already too many words. But in all honesty, you could do an entire presentation just on this slide. You could probably teach an entire course on some of this terminology. All of this comes from ASAM in terms of how they define addiction as a primary chronic disease of brain reward, which I think is all very significant. And on the next slide, I'll get into the terminology a little bit more. They talk about the ways that dysfunction in those brain circuits leads to characteristic biological, psychological, social, and spiritual manifestations or behaviors or things that we can observe. So later on, when we look at assessment, we're talking about biopsychosocial, biological, psychological, social, and also spiritual dimensions as well. So all of that becomes important with each client, each person that we're working with. We see what happens in that second box there toward the bottom. We see the behaviors manifest themselves in what I like to call the 3 C's, which are consequences, loss of control, and compulsion to use. So they use a lot of that same terminology here. So you'll hear me refer to 3 C's a lot when I talk about addiction. Again, that being compulsion to use, loss of control, and consequences in different areas of life. You see that terminology also show up in the DSM diagnostic criteria, and you see it here in the ASAM definition. So you have control underlined. So when I talk about loss of control, we're talking about inability to predict. So I can't predict how much I'm going to use or what's going to happen when I use. That craving is another way of looking at compulsion, that overwhelming, irresistible urge to do something. And then when they say problems with different behaviors and interpersonal relationships, a lot of times I'll just use the terminology consequences. And those consequences show up in legal issues, financial issues, spiritual, social, relationships, all these different kinds of consequences that addiction brings on in our lives. The last box there points out that like other diseases, like other chronic recurrent illnesses, addiction goes through cycles of remission, also cycles of relapse. There are periods where people may get better for a significant period of time, then may have setbacks. But without treatment, what tends to happen is things progressively get worse over time. So some of the key terminology, not everything from that slide, but some of the key takeaways. When we talk about a primary illness or concern, it means that that comes first. In the past, sometimes we talked about addiction just being sort of like related to some other quote unquote real problem, which isn't the case. So we know that addiction in and of itself needs treatment, needs to be the focus. Often clients come in with additional issues related to their mental health, or maybe it's related to housing, financial concerns. There can be many other life issues that are brought to the table, but addiction also needs to be an important focus and is a unique field that requires unique training and unique treatment. Chronic, like we talked about, is something that lasts over time. It persists. It doesn't just get a quick treatment and then go away. Something that's acute is something that's urgent and needs to be dealt with immediately, but typically has a shorter lifespan, so to speak. It's dealt with in a shorter period of time. I sometimes use the analogy of a broken arm. So if you break your arm, that's an acute problem, needs to be treated right away. But the solution is also relatively fast, and then it is something that once it heals, then there can be some residual problems with that, but it essentially has been dealt with. With a chronic issue, it's something that you need to deal with over time, and that's why we've set up systems of care that treat somebody over a longer period of time. Biopsychosocial and spiritual. This takes a holistic view of the individual. This is one of the unique elements of the addiction treatment field, that we look at all these different aspects of somebody's life when we're assessing them and treating them. And then finally, the term progressive, meaning that over time it tends to get worse. It's not something you can just ignore and let go on and not do anything about. So these are some of the key terms that ASAM presents to us and that should be noted. Another slide here with too many words, and I apologize. There's just so many good definitions and descriptions found within the ASAM guiding principles and within their terminology. So even before they've gotten into their assessment dimensions, they're already giving us a really good foundation to understand addiction. Understanding that admission is based on the individual client's needs. You'll see ASAM often uses the term patient. I typically use client, but we're using those interchangeably here. So we're individualizing the treatment based on somebody's needs. We don't just say, okay, everybody who comes into treatment, this is, you get A, B, and C. Now, the agency you work at may deliver certain modalities and may have certain levels of expertise and maybe even a comfort level, things that you're good at doing. You may have groups that you present, for example, that you just kind of consistently give on a regular basis. There's nothing wrong with that in any means. And you may also do certain treatment plans where it's like, I'm just kind of familiar with this terminology. What you want to be sure, though, is that whenever you are working with a client, you are seeing them as an individual and you're addressing whatever their specific needs are. You're not just doing a cut and paste or rubber stamp type of treatment plan for each person. We want to make sure that all clients receive a multidimensional assessment. So going back again to that BPS or biopsychosocial assessment, looking at all those different factors, taking into account cultural factors as well that can contribute to substance use disorders. In terms of the care that we offer, it's interdisciplinary. So it incorporates physicians, nurses, social workers, licensed counselors, addictions counselors, peer support specialists, all these different levels of expertise, all these different perspectives that come to bear. The treatment we do is evidence-based, meaning that there's support for what we're doing and for the interventions that we're choosing. It focuses on the client and it's delivered from a place of empathy. On the right-hand side, co-occurring disorders, we understand that those are a regular part of what we work with in the field. So we are prepared for clients to have multiple issues, multiple diagnoses. Mental health is often closely related with substance use issues, so we need to be aware of that and prepared to treat that. Again, treatment plans are individualized. They're focused on the client's needs as well as the client's preferences. When we get to the ASAM dimensions here in a minute, we're going to see that there's a new dimension 6, and there's some very unique language when it comes to incorporating the client's own views and the client's own preferences. We understand that there's a continuum of care. So we do an initial assessment, but assessment's also an ongoing basis. And we want to make sure that we're not just saying, well, our program is a 20-day program, no matter what. If you're ready to go at day 18, it doesn't matter. You always stay until day 20. Or if you need until day 25, it doesn't matter. Everybody leaves at day 20 or whatever the number of days is. In the past, 28-day programs have been common, 90-day, 60-day. These can give us some general idea of how long the treatment will last at our particular program, but we can't predetermine length of stay. That's the idea behind ASAM. Finally, informed consent, which everybody should be familiar with on an ethical basis, understanding that clients understand what they're getting into, essentially. So the informed consent process implies, number one, that the client is the one giving consent to receive treatment from you, and also that they're an important part of the decision-making process. So treatment isn't something that's done to you. It's something that you participate actively in. Okay, let's get into the dimensions now of ASAM assessment. So similar to the previous ASAMs, so again, this is the 4th edition, similar to the previous ones. We're using 6 categories that we assess clients on. Those have shifted around just a little bit, but we'll talk about that in just a minute. Information from this assessment is critical to guide placement in a level of care. That's what we'll talk about in the second half of the presentation. And then also, the assessment feeds the treatment plan. So sometimes we lose sight of the fact that we're gathering so much information, we're filling out these forms, we're having clients fill out forms, we're answering all these questions, and then we kind of lose sight of what we're actually doing with that information. Well, there's two main things. Number one, we're figuring out the best services that we can offer. So what's the right level of care that we can offer the person? And what will the treatment plan look like? So everything on the treatment plan should be based on what we're getting from the assessment. So that's really important. In terms of this BPS, or biopsychosocial model, remember we're taking into account a holistic view of the client that looks at biological needs, psychological needs, and social spiritual needs. So all of these are incorporated. Now, these again have shifted around just a little bit. So if you've been familiar with the old 6 dimensions, most of the same information is present. However, the names of the dimensions and some of what we're looking for have shifted. Generally speaking, our biological dimensions are still going to be 1 and 2. So that's the start of it. As far as psychological dimensions, those now look more at 3 and 6, whereas it used to be like 3 and 4 were kind of the psychological dimensions. And then the social dimensions really focus on dimensions 4 and 5, and we'll get into what those look like specifically. So on each of these next 6 slides, there will be one of the dimensions discussed. It will include the title of the dimension. And then something that they've done with this version of ASAM is include subdimensions to understand a little bit more about what we're looking at within that dimension. At the bottom on the left-hand side is a note that you'll see on each slide. And this comes from ASAM. So they've bolded some of the subdimensions, quite a few of them. Any of those subdimensions that are in bold are intended to inform your level of care decision. So those are kind of like critical elements to deciding which level of care somebody needs. Every subdimension is considered toward treatment planning, whether it's in bold or not. So if it's in bold, it tells us this is how we determine what level of care they're at. If it's not in bold, it's not as influential toward level of care, but it's more a treatment planning issue. So kind of interesting note, something they've updated here. Our subdimensions so dimension 1, is intoxication, withdrawal, and addiction medications that somebody might be using. This is pretty similar to what we saw in the past. Subdimensions include intoxication and any risks if the person is currently intoxicated or was recently. If there's any risk of withdrawal happening, maybe they're actively in withdrawal, or they've used recently enough that we're concerned about withdrawal, or it's something we need to monitor for. If the person is taking any addiction medications, something like Suboxone would come to mind here, or if they're using methadone, that would be something we also need to be aware of. Then on the right-hand side of each slide, we're going to see some questions that need to be asked and need to be addressed by this dimension. So for dimension 1, what is the risk associated with the client's current level of intoxication? If they are intoxicated, we want to know when they last used. Of course, we want to find out about their using history. So what are they using? When have they last used? Things like that. And is there a risk of severe withdrawal? So if the person has used recently, or if they are a chronic user, then they may need medical referral. The ASAM level of care is going to ask that if the person's in withdrawal or at risk of severe withdrawal, that we essentially address that right away. That becomes a kind of triage, focus on that right away issue. So we do need to be acutely aware of what substances the person has used or is using and what the withdrawal for that looks like. In some cases, ASAM also says they don't necessarily need medical withdrawal. And so one of the new features is that within each level of care, they've now included the potential for withdrawal management, even at the lower levels like level 1 and 2. Looking at dimension 2 next, we're still in the biological dimension. So 1 and 2 are biological. So here we're looking at biomedical conditions. You'll see in bold in the subdimensions, we have physical health concerns as well as pregnancy-related concerns. And then not in bold, but still an issue for possible treatment planning would be any sleep concerns. Physical health concerns is going to address whether there's any physical illness aside from withdrawal, which we dealt with in dimension 1, that needs to be addressed or may complicate the person's treatment. You'd want to know any medications the person's on, any physical limitations, any diagnoses that the person has. You also want to know if there's any other chronic medical conditions that would affect treatment, because that's going to play into what kind of treatment they receive and how we're going to deal with the treatment plan. Next, we have dimension 3. So now we've hopped over into a psychological dimension. Dimension 3 is pretty consistent with the previous version of the ASAM criteria. This time we're looking at psychiatric and cognitive conditions. The one subdimension that's bolded is active psychiatric symptoms. The ones that are not bolded include cognitive functioning, trauma-related needs, and any psychiatric and cognitive history. So if the current psychiatric symptoms are presenting a significant disability, are impacting the person's ability to function, then we're going to need to keep that in mind as far as what level of care. Other things as far as cognitive functioning, trauma history, which is mentioned here, and any psychiatric history are also important to note and then deal with in terms of the treatment plan. So we want to be aware here as far as the questions go of the current psychological state, if there is psychiatric illness, concomitant mental health diagnosis. If they are taking medications, that can be noted in dimension 2. There's nothing wrong with also noting it in dimension 3. Sometimes if you're new to doing assessment or new to ASAM, there's this tendency, I think, to try to keep each dimension in a silo and have it be almost unrelated to the other dimensions, when in fact there's all kinds of carryover and all kinds of overlap between the dimensions. They're all very closely related. Sometimes you're not even sure if a particular issue presents in one dimension or the next. It's much more important that you're identifying that concern and putting it into the assessment than it is getting it into one dimension or the other. And I've never encountered a situation where it's inappropriate to identify something in two different dimensions, especially if it affects somebody, for example, socially and cognitively, or if it affects somebody, like in this case, with like a psychiatric diagnosis, and it's also involves medication. There would be nothing wrong with listing it 2 different times if you're not sure, but at least making sure that it's addressed at some point is important. So again, looking at whether there are any chronic cognitive or psychiatric conditions. There's the phrase there, activities of daily living, if you look at the third question. So how well is the client managing their activities of daily living? And what we mean by that is just, literally taking care of yourself. Are you able to shower? Are you able to get to a job on time? Are you able to drive or commute or access other forms of transportation? Interact well with other people? Feed yourself, just access everyday kinds of things. And sometimes that's a struggle for people. And, then that may need to be an issue that's addressed. And then finally, as far as how is the client coping? So if the client does have any significant emotional, behavioral, cognitive problems, how well are they able to cope with those? What kind of resources do they have? What kind of support do they have for those things? Sometimes you'll have a client who is co-occurring in terms of having a substance use disorder diagnosis and a mental health diagnosis, but they've been taking medication for a long time. Maybe they've been working with a counselor, going to support groups, and it's something that they're actually managing very well and coping with very well. So you want to make sure they're continuing to do those things. You want to address it on the assessment, but it's not necessarily an urgent need that would take precedent. So you're just looking at how well they're functioning at the moment. Getting into dimension 4, for those of you familiar with ASAM, you'll remember this dealt with readiness to change in the past, and we often identified stages of change in this dimension. Identifying stage of change is still a good thing as far as the assessment process goes. But right now, dimension 4 is looking at substance use related risks. This is closely related to what used to be dimension 5. The subdimensions here are both in bold. So the likelihood of engaging in risky substance use and engaging in risky substance use disorder related behaviors. So one way of thinking about this is like after the assessment, if the person was to just kind of like go back on the street or go back home, what would that look like? Are they at risk of continuing to use? If they did continuing to use, what would that look like? How risky would it be? Are they at risk of overdose? Are they committing illegal acts to obtain money for drugs or obtain drugs? Are they engaging in risky sex-related behaviors, needle use, stuff like that? So all that would be significant to this particular dimension. So what's the immediate danger? Is the client in a place where they have skills to cope with their addictive or mental disorder to prevent relapse? Some of this is going to inform whether we're looking at like residential recommendation, a hospital-based recommendation, or an outpatient recommendation in terms of level of care. Does the client have insight and awareness when it comes to their relapse triggers, ways that they can cope with cravings? Do they have skills to control those impulses? Sometimes you're working with a client who has been in treatment before, maybe has maintained some periods of significant sobriety, and they do have skills and they do have resources. They just haven't been using them as successfully lately. So maybe they are appropriate for an outpatient setting, and you just need to sort of marshal those resources to support ongoing recovery. We also want to look at, is there suicidal behaviors, self-injury, harm to self or others? Those all come into play here. Next up is dimension 5, called recovery environment interactions. This is very similar to what used to be dimension 6. So if you're, again, familiar with previous versions of ASAM, some of that same knowledge comes in here. The subdimensions in bold are the ability to function effectively in the current environment. So you need to know like where they're living, who they're interacting with, what that environment looks like. Number 2 is safety in the current environment. And number 3 is the support in the current environment. The 4th subdimension is not in bold, but would apply to treatment planning. That's any cultural perceptions of substance use and addiction. So understanding that there are different cultural norms around substance use. So what are the living conditions? That's really what we're looking at. What's the environment looking like? Are there stable and supportive family members or significant others? Or are they going back to an environment that is maybe abusive, maybe other people are using in, or that isn't supportive to recovery? So we want to be aware of all those things. What does the person's transportation situation look like? How about childcare? Maybe they don't even have stable housing. Maybe it's a very inconsistent situation, and so that's going to need to be addressed. Is the person in school? Is the person working, currently employed? And what's the client's cultural background look like, especially as it relates to their recovery? Does that create additional barriers? If they have a family or a cultural belief that you shouldn't seek treatment or shouldn't seek help for your problems, or maybe that normalizes a certain amount of substance use, that can be problematic. So all those things are consideration both for where you're going to place the person or recommended level of care, as well as treatment planning. Finally, we get to dimension 6. This is a brand new dimension. This language was not in previous editions of ASAM. Dimension 6 is now called person-centered considerations. Interesting to note that none of the subdimensions are bolded, implying that these do not directly inform level of care decisions, but they should be noted for treatment planning. And I will say there might be a kind of tiebreaker. We'll get there in a second, but one of these in particular may come into play when you're unsure about level of care recommendations. So the subdimensions here are any barriers to care, so any things that would stop the person or make it difficult. Even think back to dimension 5 when we were talking about transportation, childcare. Those are absolutely potential barriers to care. So we'd want to make note of those possibly a second time here. Number 2, this is the one I find the most fascinating, is the client preferences. So in this dimension, we are taking into account where the client stands in terms of treatment modality. And number 3, we talk about any need for motivational enhancement. So if you're familiar with motivational interviewing and the stages of change, that comes into play here. So previously, dimension 4 specifically addressed readiness to change, and we often looked at stage of change. That's sort of been shifted over to dimension 6 here. I should also note that the last 2 dimensions we looked at, dimension 4 and 5, were really our social dimensions. And now with dimension 6, I feel like we've gotten back to more of a psychological individual dimension, which kind of pairs up with dimension 3 for those psychological aspects of the assessment. So here we're asking about and looking at any barriers to care. We're looking at the client's readiness for change, what stage of change they're at, and the client's preference about level of care. So this is implying that if the client has a strong feeling, for example, they're adamantly opposed to doing residential treatment, but they are willing to do some type of outpatient treatment. It doesn't mean that you can't recommend residential or that that isn't the appropriate level, but that's at least to some extent taken into account here. We're asking about it and we're considering it. When I said tiebreaker, my thought here is that if you are right on the fence, let's say between like a level 2 intensive outpatient or high intensive outpatient care versus some level 3 residential program. ASAM's general guidance is that we use the least restrictive level of care that is still going to be effective. And so if there's truly, on the fence between like a residential and an intensive outpatient, it might be appropriate to incorporate what the client's preference is. Their ability to access level of care could be considered here as well. So the client isn't necessarily the one making the decision, and we're not deferring to what the client prefers, but this is at least saying that we can be aware of that and have some consideration for the client's feedback in terms of preferences about level of care. And it's also going to speak to their willingness to engage in the treatment process and how cooperative they're going to be. So if the client feels like they're being forced into a level of care they're uncomfortable with or they don't want to be at, it's more likely to lead to a certain level of resistance and difficulty engaging in the process. So dimension 6 is addressing that in an interesting way. So some key questions. This is kind of a summary or almost a cheat sheet of what we're looking at in each of the dimensions. So dimension 1, is the patient intoxicated? And again, patient versus client, that can be interchangeable here. Is the client in withdrawal or expected to enter withdrawal soon? Those are two of the big things we need to know. In dimension 2, is the client experiencing physical health problems? Is the client pregnant or likely to become pregnant? Those are some of the key things we're looking at. Medications can also get addressed there. Dimension 3, does the client have active co-occurring mental health symptoms? And does the client have any psychiatric or cognitive problems that we're aware of? Again, these are not necessarily all the questions you need to know or all the questions you would ask, but they are some of the key things that we want to find out in each dimension. They're kind of the bare minimum that we want to know about the client within each dimension. For dimension 4, how likely is the client to engage in risky substance use if they don't receive some type of treatment or intervention? And then how likely are they to engage in risky substance use related behaviors such as selling drugs, committing some type of criminal act like robbery, engaging in sex work for drugs? All those things would be related to the risky behaviors. In dimension 5, we want to know what the client's current living environment looks like. Is it safe? Is it supportive? And is it conducive to recovery? Finally, in dimension 6, is the client able to attend the recommended level of care? So if I say you need to go to 3 or 4 groups per week, but it's 30 miles from your house and you don't have a good means of transportation, that's probably not the best recommendation. We might need to look at some alternative. And then, is the client willing to attend the recommended level? Now, for some clinicians, that may strike a chord. You might even be a little bit uncomfortable, saying that the client is getting input into what their recommended level should be. And again, it's not that they are the ones deciding. It's just that we're being sensitive to that input and we're at least taking it into account and just appreciating that it could be something that influences their level of engagement and willingness to cooperate with the process. Okay, so that was the first part of ASAM, which dealt with doing the assessment. And again, the assessment feeds both the treatment plan and the recommended level of care. So the next part of this is the continuum of care, which is the different levels of care that we can recommend. So we base our recommendation on how severe the problems were from the first 6 dimensions. The services and recovery process are viewed along a continuum. So it's not just, okay, you get this one and only one level of care and then that's it. There's a lot of flexibility. It can be a dynamic process. Often we look at a step down model where you move from one level of care down to a lower level of care, maybe even on to aftercare, and then ultimately, ongoing treatment, ongoing support, maintenance, if you will, of the recovery process. So you as the clinician will determine an appropriate level of care initially, but then on an ongoing basis, we evaluate the appropriateness for the client remaining in that same level of care. So you'll hear terms like continued stay review, utilization review, ASAM review. This implies that we're doing assessment on an ongoing basis and we're making sure that our recommendation fits with the level of care somebody's receiving. So assessment is done upfront initially prior to treatment, but it's also an ongoing process. And again, ASAM recommends the least intensive level of care that can safely and effectively support what the client needs at that time. Sometimes we are kind of in between two levels of care. So you want to make sure you've gone through the assessment and gone through the criteria very carefully. Sometimes having a conversation with a peer or with a supervisor can be useful as well. Okay, so on this slide, we are looking at an overview of the various levels of care. I'm starting at the top with level 4 and then moving on down to level 1. And then below that, they've identified recovery residence as sort of its own category. So level 4 is the most intense, provides the most restrictive type of care, and it's medically managed, it's inpatient treatment. Typically, we think of a hospital setting for this. As you move down toward level 1, it's less restrictive, it's less intensive. On the far right side, you'll see in that kind of dashed box, that's all medically managed care. So that applies to each of the levels 1 through 4. So sometimes we think of medical managed care as only being in level 4, but it can actually be done at level 1, 2, 3, or 4. So they've now come up with a new designation for each level at 0.7. So 1.7, 2.7, 3.7. Those are all medically managed care. On the next slides, we'll get into some of the specifics of what each level implies. In that other box, in the middle of the page there, you have clinically managed care. So those are clinically managed, counselor-driven settings, and that includes a lot of the treatment that we're probably most familiar with: outpatient, intensive outpatient, residential settings. Then on the left-hand side of level 1, we have a new, never seen before level, which is 1.0. The name of it is new. In the past, level 1 was just outpatient. But what they've done is gotten rid of level 0.5, which was a kind of education level, risk reduction level of care in the past. And now they've called that long-term remission monitoring. So that's level 1.0. And they've slid outpatient over to 1.5. So that 1.0 is something I think the field is still deciding on and defining what that looks like, and of course whether treatment will be paid for at that level by insurance companies. But that looks something like an ongoing aftercare program. So maybe somebody's completed IOP and or OP treatment, and then they're just coming back for occasional contact with a counselor or with a group, which would be a fantastic and very useful thing. The question is, how would that be paid for, I think. Then separate from that, they've included something called recovery residence. And so this would be something like a 3-quarter house or a sober living home. It is not the same as what we typically think of as halfway houses, and I'll define that a little bit when we get to dimension 3. So 3.1 is a clinically managed level of care. Recovery residence at the bottom would be something you're not going to get reimbursed for. Typically, it would be something like a sober living home. Throughout the United States, you often see Oxford houses. This would qualify as that. So you're recommending somebody to get some kind of stable, supportive housing environment that is somewhat part of the continuum of care and somewhat outside of it, because those are typically not licensed to provide treatment. So it would be somebody going to like outpatient or intensive outpatient, but then also living in a separate sober residence. Okay, let's break down each of the different levels. So level 1 is still called outpatient, but we've now added 1.0 as this long-term remission monitoring. So I would say think of aftercare. This is ongoing monitoring for clients who are in stable remission, longer-term recovery. Outpatient now is 1.5. Outpatient for adults is less than 9 hours of counseling or service per week. For adolescents, that's less than 6 hours per week. Some of the basic goals are to discuss the recovery process, look at motivational enhancement strategies, kind of increase the motivation for change, move somebody through the stages of change, kind of make a commitment toward long-term recovery. Again, with each dimension, we have a 0.7 here, 1.7 being medically managed outpatient. That may sound a little bit strange to some people. Essentially, it's the same as 1.5, but we would also have the medical capacity to monitor somebody for withdrawal, make sure that if they are going through any type of withdrawal, they can do so ambulatory on an outpatient basis, that they're safe, that they're stable, maybe that they're taking any medications for withdrawal that they need to be on, and that if needed, we could quickly refer them to a hospital or other type of service if it became more severe. With level 2, we have what I'm calling IOP and high IOP, so IOP and high op. It's intensive outpatient, which is 9 to 19 hours per week if you're an adult, 6 or more if you're an adolescent. Incorporates an interdisciplinary team, and it's capable of providing co-occurring disorder treatment. This is the same as in the third edition of ASAM. It's still 2.1 is IOP, intensive outpatient. No significant change there. For 2.5, we have a new name. Used to be called partial hospitalization. I think there was some stigma around the concept of it being hospitalization. And so instead of being PHP, we've now renamed it high intensity outpatient or high op. This is 20 hours or more per week of treatment. It is still done in most likely a hospital, possible clinic setting, up to 5 days a week, multiple hours of programming each day. You typically have nurses, sometimes doctors on staff, social workers, counselors, so a pretty significant team of people, and it's at a more high intense because they're going to groups typically throughout the day. And then within Dimension 2, you also have the 2.7, which is similar to the 2.5 setting, but with additional medical capacity to monitor and manage withdrawal. Okay, moving up to level 3. This is now residential level of treatment. 3.1 is also basically unchanged from previous versions. So 3.1 is a clinically managed, low intensity residential. This is our halfway houses and licensed recovery homes. So if you have an unlicensed, kind of like sober living home, that would be what they're calling recovery residence, to distinguish it from a level 3.1, which is run by clinical staff. There needs to be staff on duty 24 hours a day. Typically, the residents are out of the house during the day. They're either going to school or working or looking for work. But then they come home every evening. They would go to maybe mutual help meetings, such as 12-step meetings, and there needs to be included at least 5 hours of clinical programming each week. So it could be 1 hour a night, but something that's clinically managed in addition to the other requirements of living in that residency. In the past, there was a level 3.3. That's been gotten rid of. That no longer exists. Next, we jump up to level 3.5. Clinically managed high intensity. These are our residential longer term stay programs. I hesitate to use the terminology because it's a little bit dated, but if you're familiar with something like a 28-day program, that's kind of along those lines. Keeping in mind that we are not supposed to have fixed lengths of stay, but just to have that kind of model of what this looks like at level 3.5. We have 24-hour care available. We have trained staff, typically, again, a very multidisciplinary staff. Clients do need to be able to tolerate a high intensity setting because there's going to be several other people there. They're going to be living there. They're going to be seeing and dealing with each other all day and all night in a residential setting. You might have a unit with a dozen, 2 dozen, 3 dozen different individuals living together. Some of these units are co-ed, some are one gender, but it's typically a more high intense type of milieu and environment. So you need to be aware of that and make sure that the person is able to tolerate that if they're recommended to this level of care. The advantages of the high intensity setting are that, there's kind of like a constant enforcement of group norms. It's much more difficult to obtain drugs of abuse, not impossible, but you have staff there all the time monitoring people, typically screening people when they leave and come back in. So it definitely is more conducive to recovery and sobriety, and can be a really good transition for somebody who's early in recovery. In this setting, you need to have at least 20 hours of scheduled programming each week. And then for level 3.7, it's similar to 3.5, but you would have additional expanded medical capacity to monitor and treat withdrawal. Finally, level 4, this is our highest level of care, highest intensity. This is medically managed inpatient. Here we're talking about hospitalization with 24-hour medical care, daily physician availability. In this level, you're required to do a daily continued stay review. So typically these are short-term, 3 to 5 or 6 days on the high side. The goal is to try to stabilize somebody and then move them into a clinical level of care, maybe a 3.5 or a 2.5, and not stay in this level for an extended period of time. But typically somebody is experiencing withdrawal or other significant medical needs that have to be addressed before they can live or work in a clinical kind of setting. And when I say work, I mean engage in a clinical level of care. Okay, so a few things to consider here and just a few slides left. When we look at dimensional severity and placement, so there are some roadmaps within the ASAM guide which help identify what level of care is most appropriate. Generally speaking, when we're talking about lower severity within the dimensions, so lower intensity of psychiatric problems, lower intensity of medical problems, a less severe and concerning physical environment where there's minimal current difficulties, then somebody looks more appropriate for outpatient type of care. As we get into maybe kind of a medium range where there's moderate difficulty or impairment, there's difficulty coping, but there is the ability to function with clinical support, then we're more appropriate for like a level 2, which is intensive outpatient or high intensity outpatient. And then if we're looking at higher severity with severe difficulty or impairment, a really poor ability to cope with problems, then that's going to call for that level 3 residential or even hospitalization if there are acute medical and psychiatric needs. When we diagnose immediate withdrawal, when we diagnose severe psychiatric issues, severe medical issues, those do need to be addressed right away regardless of what's on the other aspects of the assessment. In terms of withdrawal management at all levels of care, it's important to monitor clients for withdrawal. So even though somebody says they haven't used recently, or we don't right away notice withdrawal symptoms, we still need to be aware of those because they might come on, suddenly, or somebody might not have been honest about how recently they used. So when we see those, we need to address those. If somebody is a chronic user, meaning they've been using for a long period of time, or they've had very recent use, safe withdrawal is absolutely critical to address. We should put it on the assessment. We should consider it for their placement in level of care. And we should make sure we address it through our treatment planning as well. In terms of what level of care you do the withdrawal at, if they are experiencing some level of withdrawal or there's withdrawal risk, the level of care depends really on their ability to comply with medication. How severe is the risk of withdrawal? Have they experienced withdrawal in the past? How has that been dealt with? Those are all things we're looking at. If somebody is, for example, an opioid user, but they are compliant with Suboxone or another similar medication for withdrawal management, then it tends to be easier to put them at a less severe level of care, less intense level of care. If somebody's not compliant with those medications or inconsistent, that may be a reason to have them in a residential setting where they're going to be given that medication daily by a nurse or physician. All levels of care are expected to provide access to addiction medication. So it's not up to the treatment program. If somebody is taking medication for treatment of addiction, buprenorphine, for example, Vivitrol, acamprosate, different things that may be used to treat cravings or withdrawal, they are expected to be able to access those medications. In terms of co-occurring disorders, At all levels of care, we need to have some co-occurring treatment available. If our program doesn't provide it, then at the very least, we need to be able to provide a referral and make sure that we're coordinating that treatment, either with a therapist or with another facility that is providing that. Ideally, we would offer groups and counselors who are trained to be able to treat co-occurring disorders as well. As we get up higher intensities of care, such as residential treatment, and even in high intensity outpatient, we have to be enhanced, co-occurring enhanced, in order to provide the treatment directly through our program. Clients who have multiple diagnoses and who are co-occurring, that should be seen as the norm rather than the exception. So for a long time, we kept ourselves in silos as far as mental health treatment and addiction treatment, and they are two separate things, but because they are co-occurring and because more of our clients have that diagnosis than not, we need to be able to address and be prepared for both. So clients should have that knowledge as far as the experience working with that population, familiarity with mental health recovery, resources within the community. And if you don't have that, that's something to address and to keep getting better at. One term they use is opioid treatment program as kind of its own specialty standalone program. So this would be a program that offers either methadone and or Suboxone to clients while also providing outpatient or intensive outpatient services. Technically, this can be offered at all levels of care as appropriate. So somebody might be, level 2, level 1, but we still can offer opioid treatment, even level 3 as well, residential. So we want to be able to do the case management. We want to be able to connect somebody with resources, continue to provide the medication, which can both prevent cravings and prevent withdrawal and help sustain recovery. So for opioid use disorder recovery, right now, this is seen as the kind of basic standard of care, that the expectation is that for most of our clients, they are engaging in some type of opioid treatment to sustain their recovery. And then in terms of withdrawal management, we have touched on this, but in the past, it was really focused on at the higher intensity levels of care, but now it's available also at outpatient levels with monitoring. So levels 1, 2, 3, and 4 all incorporate all incorporate withdrawal management. So it's now embedded into the levels of care. It's not a separate service. So all levels of care need to be aware of withdrawal and have some access to withdrawal management. There's also a short but very good section in the ASAM about post-acute withdrawal syndrome, PAWS or PAWS. Understanding that PAWS is not a medical condition, but PAWS is something that many, if not most, clients will experience, and they want programs to be aware of it and be able to address it. So it doesn't affect like a medical placement. So if somebody is experiencing PAWS, it is, again, very common. It's the emotional, physical, long-term consequences of using that are happening, but it's not the same as an immediate medical withdrawal. But sometimes people will experience cravings, using dreams, anhedonia, or like a lowered mood, inability to experience pleasure, sometimes just difficulty experiencing any affect or any range of mood. And range of feelings. Those are often related to post-acute withdrawal. So again, very common. We need to be able to talk to clients about it. We need to be able to address it in our programs to explain that it is normal, but that as our brains heal over time, that does tend to improve the longer that we've been in recovery. Okay, coming close to the ending here now. Counselor skills and interventions. So how do these relate to ASAM? Think about motivational interviewing as far as a tool to move through the change process, move through the stages of change. That's a great way to meet clients where they're at, and you can even focus treatment around trying to move onto the next stage of change and move forward in the change process. Relapse prevention is something we should be able to address at all levels of care. I think in most treatment programs, it is embedded as a theme It's a group topic. It's a focus of treatment planning and long-term recovery. So I think we do a really good job addressing relapse prevention, and we need to continue doing that. We also want to look at emotion management and regulation, being able to cope with cravings, knowing that they are going to occur at certain times. So finding different tools that are successful for the individual to cope with cravings, emphasizing self-care, emphasizing routines like we talked about, activities of daily living, and doing things that are successful, healthy habits. We also need to be able to connect people with community resources. We provide as much as we can in our programs, but we can't do everything. So we want to have resources for employment help. Maybe sometimes it's as basic as, job searching, resume writing, how to do an interview, where to look for a job. So not just saying, well, go get a job, but what resources are out there? How can we support clients in that process? Mutual help groups. So self-help like 12-step recovery, smart recovery, celebrate recovery. There's a lot of really good resources out there. These are free. They're in many communities. I think they're a great tool for clients to use both in treatment and during their aftercare stage. Some clients need support with transportation, legal issues. Housing, of course, is a huge one. If somebody's unhoused, it's really difficult to do anything else productive in the meantime. So just having those referrals, having connections, and understanding what a client's needs are very important. And the final slide of this presentation is kind of an unofficial slide, if you will. So if you want to cut the presentation off at this point and say, I've had enough, I've got enough information, that's totally okay. This is just in my own experience, so I'm going a little bit off book here. But if you're familiar with DSM, which is the book we use to diagnose or create a diagnostic impression, I've tried to create a link between the DSM diagnosis for substance use disorder and placement and level of care. Again, this is not directly from ASAM. This is not official. This is kind of just a general guideline. So there are 3 different levels of severity in the DSM. There's substance use disorder, mild, moderate, and severe. So if you were to look at 2 or 3 diagnostic criteria, which would be in that mild category, there would be a general inclination that maybe level 1 would be appropriate, possibly level 2, but it would lean toward a less severe level of care if there wasn't an immediate concern about withdrawal or medical issue that needed to be addressed right away. If you had somebody in that moderate category, which means 4 or 5 diagnostic criteria, that would suggest to me more of a level 2, somewhere in between, like intensive outpatient or high intensity outpatient. And then if you had somebody with 6 or more criteria, meaning they meet the DSM for severe, I would think that implies more of a level 3 higher intensity level of care, or maybe a 2.5, or even a level 4 if there are medical needs or withdrawal needs to address. Generally speaking, greater severity is going to mean a higher level of care. That is consistent with ASAM language. And of course, withdrawal and immediate medical needs have to be addressed first. So I just provide this if you are sort of new to ASAM and you're just unsure. This gives you some kind of boundary or guideline to work with. You always still want to use good clinical judgment, use the specific information from the assessment, and use supervision where appropriate. Okay, that is a wrap for ASAM 4th edition. I hope this is somewhat helpful to you going forward. I encourage you to reach out to me if you have any kind of questions or concerns, and best wishes.